We will now begin talking about topics, the first of which is asymptomatic hyperuricemia and when to treat it. The first thing is to define that asymptomatic hyperuricemia refers to an elevated serum urate concentration without the presence of symptoms or signs of urate crystal deposition disease. Therefore, asymptomatic hyperuricemia refers to having high uric acid levels without gout or kidney disease caused by crystal deposits. What levels of uric acid are considered hyperuricemia? The level we will consider is 6.8 nimiganos per deciliter, which may seem like a somewhat arbitrary value. However, it corresponds to the solubility limit of urate under the body's physiological conditions. Above this concentration, there is already a risk of crystal formation and precipitation, and it is the point from which the risk of developing gout and other complications increases significantly, associated with hyperuricemia. Alright, to develop hyperuricemia, we mainly have two pathways, either through increased production of purines. Here, we can highlight genetic disorders, as well as those associated with diet or the use of medications, notably, as we mentioned earlier, alcohol consumption. And then there are certain clinical conditions that can also lead to increased purine production, such as myeloproliferative and lymphoproliferative syndromes, hemolytic disorders, psoriasis, tissue hypoxia, Down syndrome, and diseases related to glycogen storage. The other way we can increase uricemia, such as in the human body, is by decreasing its excretion. We have therefore chronic kidney disease, lead nephropathy, also known as Saturnine gout. The depletion of effective volume, diabetic ketoacidosis, lactic acidosis, preeclampsia, and obesity are some of the clinical conditions that can lead to a decrease in purine excretion, as well as genetic diseases, such as I mentioned earlier, and other factors. In this chart, we can see the different mechanisms that contribute to the increase in uric acid, whether it's this group here, which includes tumor lysis, alcohol, fructose, lactose, purines, or factors like obesity, age, or kidney disease, which ultimately lead to elevated uric acid levels. And regarding hyperuricemia, just as we mentioned earlier, it should be understood as a continuum. Gout begins with an initial phase of asymptomatic hyperuricemia, and in this article involving Dr. Eliseo Pascual, it is shown that within asymptomatic hyperuricemia, two groups can be distinguished. The first is a type of hyperuricemia in which there is no crystal deposition, no ultrasound abnormalities, and no clinical symptoms. But it is the second group here that current studies on asymptomatic hyperuricemia are focusing on to determine whether treatment is necessary. These would be patients who show abnormal lab results and in addition have confirmed crystal deposits by ultrasound without any associated clinical symptoms. When clinical symptoms begin to appear, we then move on to discussing those gout scenarios we mentioned earlier. And speaking of that, we come to this section here where we specifically discuss the article by Dr. Peral and Dr. Mariano Andres, who in particular talk about those patients in the middle columns compared to normuricemic individuals, which would be the first column. Moreover, it is important to note that in this context, as we delve deeper, the comparison is crucial. And gout patients, which would be the last column, we can indeed see how patients with asymptomatic hyperuricemia and confirmed crystal deposits demonstrate an increase in acute phase reactants and an increase in all the cytokines that were studied in the article. Therefore, we can say that asymptomatic hyperuricemia represents a pro-inflammatory state. But what does our guideline say about this matter? Both the European group and the American group currently recommend not treating asymptomatic hyperuricemia. In this specific context, as of now,